Right, hi. For those of you that don't know me, my name's Steph Hewitt. I'm one of the AMPs based over at St Helens. First of all, apologies, this isn't coming to you live, but this was a last minute swap over of schedules. I've actually got patients booked in Wednesday morning. So I thought probably the best thing to do, with rather than juggle around with patients, was to just pre-record and upload this to YouTube for you, so you can watch at your leisure, and if you're so inclined, watch again. Second, a little bit of housekeeping. I'm currently at home. I've got 2 children that are prone to squabbling, and a puppy in the background, so if you hear arguing or barking, then apologies. I've tried to shut as many doors as possible, so hopefully it won't be too distracting. I was asked, as sort of part of this series of in-service trainings, to look a little bit more at exercise and exercise prescription. Very much the plan is that this will be the first of a series of talks on this subject. So very much the aim of today is just to do quite a lot of revision, so hopefully it will serve as an aid memoir for you, just sort of really the sort of principles behind sort of basic muscle physiology and strength and the like. So hopefully there won't be anything too unfamiliar, and hopefully as I've gone through it, there's been lots of, oh yeah, I do remember that from physiology at uni, which for me was quite some time ago. So as you see, I've called it Getting Stronger. So those of you that have listened to me doing service trainings before know that I love a good quote. So this is taken from Greig and Jones. Problems with muscle function may not appear as dramatic as failures of the vital organs, but ultimately our mobility and independent lifestyles, not to mention our ability to breathe, cough, speak and swallow, all depend on the proper function of voluntary or skeletal muscle. And in a nutshell, this is why a lot of us are in MSK doing what we do for a living. So if we just reflect a little bit on where we were, where we are now and where we are heading to, particularly with regard to exercise prescription and sort of what the advice we were giving to our patients. So pre-COVID, were we doing enough? Were we giving our patients accurate enough information about when to exercise, how often to exercise, how much to push themselves when they exercise, sort of what point to take it to? Were we being clear enough with numbers of reps and sets? And if we were, was that kind of grounded in the evidence, or was that more what somebody had told us and that's what we heard in the next cubicle being done, so we thought we'd go with that? So were we doing the absolute best for our patients when it comes to prescribing or using exercise as a management tool? And I think there are times when we weren't. We could have been doing better, but we had other sort of things we could do that could kind of compensate for that. As we've gone very quickly into lockdown, there's been a rapid transformation in how we deliver our services. We've lost our objective assessment, essentially. And certainly I remember at university and in my earlier sort of days in my career being told it's all about the subjective, and the subjective is where you find out all your information, and your objective is just there to kind of confirm what you think you figured out. And for me, one of the biggest sort of things I've noticed during lockdown is just how important our objective assessment is, not just from the kind of obvious, the sort of measurement techniques, our neuro screening, our assessment of muscle power, reflex testing, just sort of how a patient feels and moves and what we can see when we're sort of up close to them. It's such a fundamental part of who we are as a profession and what we do as a profession. But not just the obvious stuff, it's all the slightly more subtle things that you don't necessarily think of until that situation is removed from you. So it's that face-to-face interaction with patients, it's those verbal and non-verbal cues, all those things, you know, when a patient becomes distressed, it's popping a hand on their knee, it's everything we do when we're in a cubicle or in a room with our patients. And I feel we've really sort of lost a fundamental component, not only of our assessment and our management strategies, but as part of our profession, you know, sort of day one, lesson one at physio school, it's kind of whip your tops off and have a poke and prod of each other. And that's gone sort of overnight, really. So then when we can apply that particularly to a management perspective, managing our patients, the tools we have at our disposal now have really shrunk down, and we have advice, education, but perhaps most importantly, exercise. And so it's absolutely imperative that we get that exercise right for that patient, sort of now more than it's ever been. As we start to see the easing of lockdown restrictions and we start to move towards hopefully a pace that is certainly not necessarily post-COVID, but with COVID well under control, I think we're looking at a potential increase in musculoskeletal disorders. I think anybody who is walked outside the house over the last 7 weeks will see that there are a lot more people running, there are a lot more people cycling, and you do wonder whether rates of things like tendinopathy are on the rise, and as doors start to open again to services, whether there's going to be an influx of musculoskeletal disorders. We've changed the way we work, and I don't think anybody in the profession at the moment thinks that everything will go back to exactly as it was. So I think we will see more virtual consultations. So again, we have to make these as effective as possible. I also think that it does really bring challenges for our profession for all the reasons I've just discussed. Objective assessments, face-to-face interactions with patients are a fundamental component of our profession. And so I do think our profession faces some challenges, and we have to be ready for those. So the aims of today really are to revise muscle physiology and to provide a bit of a grounding for what's going to come up over the next few weeks. Rachel O'Toole and I, for those of you who don't know Rachel, she's one of the Band 6s over at, based out of St Helens, with a really strong background in sports rehab and strength and conditioning. And we've been working together. It was our plan before we went into lockdown to do an in-service training with everybody, to exploring kind of strength and conditioning concepts and how we can apply those to our patient population. So we've now had to flip that a little bit more so we can deliver it remotely, but that's what we're going to be looking at hopefully over the next few weeks. Our plan is to discuss exercise prescriptions, so specifically dosage, number of reps, number of sets of reps, sort of when, what, how and why, and how to progress, when to progress, and then how to regress if you've got a patient that's struggling. And when we are working remotely, what are the things that we can do to consider how we measure strength, power and endurance gains in patients while we are socially distancing and not able to use biceps to assess somebody's quads, etc. So the idea of today is just to give you a sort of hopefully useful refresher and reminder. So just a little bit of background context for the patients we see and for society generally. Peak muscle mass is reached in girls in their mid to late teens and in boys in their late teens to early 20s. And this is maintained until the 4th or 5th decade. From aged 50 onwards, we get sarcopenic changes, or a loss of muscle mass, which can be between 1 to 3% per annum. And if we think about us as a population and how we're living longer, that's a pretty significant volume to be losing if if we're going to be living well into our 80s and 90s. The rate of decline of muscle mass and strength is accelerated by disease and illness. And the example that I'll give you, if we look at a fractured neck of femur survivor, they are 40% weaker and 70% less powerful than age-matched counterparts. And I'm going to go on to discuss the difference between weakness or strength and power. Therefore, it's absolutely crucial that we prescribe the exercises that will provide the maximum benefit for that patient at that moment on their patient journey, and that we gain that patient engagement and sort of get them to really go with sort of what we want them to do whilst we're working remotely and we're doing it either via the phone or via a screen. So this is the bit of the presentation where I would normally put you into small groups and give you a piece of flip chart paper and a pen and say, discuss what you think muscle strength is, what you think muscle power is, and what you think muscle endurance is. And let's all get back together in 5 minutes time. So obviously not really an option. So just quickly have a little think. I'm not going to sit staring at a screen quietly. So what is strength? This definition is from the American College of Sports Medicine in 2007. You will find lots of other definitions of strength, but this one I quite like, it makes sense. It's the ability of a muscle or a muscle group to develop a maximal contractile force against a resistance in a single contraction. This definition I actually took when I was having a bit of a look from a lot of work by a lady called Claire Minshall. You may well have heard of her. If you are on Twitter, I encourage you to follow her. Her website is Get Back to Sport, and I've put that on as a reference at the end. And she's very intelligent, very well read, sort of physio with this really strong strength and conditioning background. And I've sort of utilised a lot of what she talks about in the presentation today, and then again a lot of what she talks about perhaps relates more to a more athletic population of patients. Obviously we don't necessarily see that in Knowsley and St Helens, but still we can apply the same principles. The principles of strength and conditioning training should be, you know, they can be used across the spectrum, from some of the really deconditioned patients that we see up to you know, sort of those high performing athletes. But one of the useful things that Minshall discusses is the concept of strength as a fuel tank, and really that idea of capacity of strength. And if you've got a really, really good reserve of strength in your fuel tank, you've got a really good capacity then to do activities of daily living, such as walking up the stairs, only dips a little bit into that fuel tank, and you've got the capacity for much more. If you are weak and there isn't that capacity, then you are working to your maximal strength, using up that fuel tank just walking up the stairs. So when we think of strength and why is strength important, well, we need it for activities of daily living, as discussed, for general day-to-day skills, for specific skills with certain sports or activities that we do or do a lot. We know that strength is important in reducing the risk of injury and illness. That concept again of capacity, sort of from the reduced fatigability, and we know that sort of higher sort of levels of muscle strength are associated with an increased metabolic rate. So what is power and endurance, and how does that differ from muscle strength? Well, power is essentially the speed of your force production. So that's the optimal amount of work performed in a given time period. It's also, you'll see it referred to, and certainly in this presentation, but in other bits of literature as well, as your RFD or your rates of force development. And this is really important because you can have two patients who you test with, say, a dynamometer, who have the same levels of strength. So if you imagine sort of a graph with the curve that kind of comes in, because we know sort of muscle activity hits its peak pretty quickly. So it'll shoot up to kind of the maximum muscle strength sort of very quickly. If you've got somebody that has less power but the same level of strength, they will hit that peak much later on that curve. And that's really important, because if you think about injury and mechanisms of injury, injuries generally occur at speed, and not just on the sporting ground. You think about turning an ankle or twisting a knee or sort of a slip downstairs, all the things we see clinically day to day that are a bread and butter. Those are injuries that occurred at speed, and so therefore we need that power, that response time of that muscle to kick in to maximum strength as quickly as possible to provide that rapid dynamic stabilization. So that's power. Endurance is your ability to perform a specific muscular activity or action for a prolonged period of time. So repeatedly exerting a submaximal force. So when we start to consider the factors that affect muscular strength development, there are quite a few. What I'm going to sort of touch on today is motor unit recruitment, so that's properly back to basics physiology. Your muscle CSA or your cross-sectional size, your musculotendinous stiffness and the role that plays, and then briefly just touching on firing frequency, motor unit synchronization, and then your neuromuscular control or neuromuscular inhibition. So that's what I'm going to look at today, but you've also got to bear in mind, you've got to sort of consider the role genetics play. We've got to consider baseline strength. So obviously in quite a few of our patients, we've got fairly deconditioned or low levels of baseline strength, which means if we can get a patient to engage in the strengthening program, we should see good gains, and we should see those gains pretty quickly because we're starting from a low point and sort of aiming only in one direction. And we also need to bear in mind current activities and training levels. And again, for some of our patient population, it's pretty absent. But we do see, people that do sort of exercise more regularly, and it's bearing in mind what they're doing already when we're thinking about the gains we're hoping to make. So, as I said, as I promised, right back to basics. So your motor unit recruitment. So skeletal muscle fibres are innervated by a single branch of an axon arising from an alpha motor neuron in the spinal cord. An alpha motor neuron and all the muscle fibres it innervates we refer to as a motor unit. We've got different sizes and excitabilities of your motor neurons, and also different sizes and excitabilities of the motor units. So the recruitment of these alpha motor neuron cell bodies in the spinal cord determines which fibres are active during the movement. So if we think about the smaller motor neurons, these are more readily activated. It's a lower level of excitation to kind of switch them on, if you like. But they tend to innervate relatively small numbers of fibres or motor neurons, or motor units, sorry. Your larger motor neurons, they are less excitable. So it requires more to kind of switch them on. They have greater numbers of axonal branches and therefore control larger motor units. Now, this next bit is going to look like a complete cop-out, and in some ways I suppose it probably is. However, it's a video I found on YouTube that I think explains sort of the whole actin, myosin, kind of sliding filament theory, your troponin, your troponomycin, everything that we kind of vaguely remember from muscle physiology. And it explains it really nicely. And if you're anything like me, I'm a really visual learner. I need pictures and graphics and models in front of me. I started to try and put together all sort of the sort of revision, if you like, of muscle physiology contraction onto slides, and then I remembered I'd watched this a while ago when I was going over looking at these concepts myself, and I thought, this is as good as anything. So you're going to have to overlook the American accent, and you're going to have to overlook that it's quite patronising, and it sounds like I'm directing you towards, kind of year 7 biology to begin with, but just grit your teeth for the first sort of 30, 45 seconds, and then you'll find it is quite a nice summation of the process of muscle contraction, the chemicals and processes involved in how we produce contraction, and a revision of the sliding filament theory. So pause me, click on the link, and then come back when you've watched it. Okay, so I hope you enjoyed that and weren't too patronised or offended, but I thought it was quite a useful little summary. So whether the alpha motor neuron fires or not depends on both excitatory and inhibitory inputs. So, for example, a joint inflammation or damage will cause an increase in inhibition, which will therefore lead to less motor neurons firing, therefore less motor units firing, therefore weakness in the muscle. Flip side of the coin, which I know is not something we commonly see, but it's kind of the best example I could find from this perspective, tetanus. So what tetanus does is it prevents the release of the inhibitory neurotransmitter, and therefore you reduce your levels of inhibition, which means you end up with an uncontrolled contraction. So I appreciate not very applicable to us, but when we look at the things that are applicable to us, such as spasm and cramp, we don't quite know whether if that is a result of increased excitation or whether it's a result of reduced inhibition. But either way, I'm sure all of you have experienced cramp at some point. What do? We either grab our calf, if it's calf that's gone into cramp, and rub it, or we leap out of bed and we stretch it. And what we're doing there is stimulating the Golgi tendon organs which increase our inhibition and reduce that contraction. Your smaller motor units, include your slow twitch type 1 fibres. So they are recruited, they require low levels of excitation, they're recruited with sort of smaller force magnitudes, or smaller sort of rate of force development is required. They're recruited early and they're recruited frequently. So activities such as walking, standing, sort of low level activities, if you like. And those are the things that are holding us up or allowing us to move. They are slow contracting. They are they have a high oxidative capacity, which therefore makes them relatively fatigue resistant. Your larger motor units have a higher threshold, so they require more excitation to get them going. They are used when a rapid or large contraction is required, and these are your fast twitch type 2 fibres. So you've got type 2A, type 2X and type 2B. So when then we kind of apply that to a little bit sort of clinical practice, consider the differences in sort of appearance and sort of muscle mass in long distance runners than in weightlifters. So your long distance runners, they recruit your low threshold, slow fatiguing type 1 fibres. They only recruit the type 2 fibres when type 1 fibres are fatigued. So if you then sort of think about examining an MVC, so the maximum voluntary contraction, in say the quads of a long distance runner, your maximal strength generated will be relatively low, and that is due to the infrequency of the recruitment of the larger motor units that contain the type 2 fibres. So yes, they're unbelievably fit from a cardiovascular perspective, and they are still sort of strong, but if you compare their maximal strength in say the quads with somebody like a weightlifter, then there will be a huge difference, and that is down to the sort of the motor units, or the types of fibres that are in the motor units that are recruited most frequently in your long distance runners, and they only dip into those type 2, those larger motor units, when they fatigue. Weightlifters, on the other hand, sort of like use ballistic movements, small number of repetitions, but sort of repeated sets. You'll see them do a few lifts, but they'll do that several times with a high weight. So therefore they recruit both types. Either recruit the type 1, standing around, that's what's keeping them up, but they recruit the type 2, the larger motor units, when they're doing their dynamic activities, such as your clean and jerk. Therefore, both types of motor units are trained. Therefore, it's thought to be a more effective way of developing strength. So it's beneficial to recruit type 2 for strength development. Ballistic and heavy resistance training exercises promote the recruitment of the larger motor units with the type 2 fibres at, so it's not just that they recruit them, but it's also with repeated those sort of doing those ballistic, those heavier resistance training exercises, that you also will get that recruitment of those larger motor units with the type 2 fibres at a lower threshold, which again raises the potential for positive strength and power gains. Now, I'm not suggesting that we send every osteoporotic granny with a flare-up of their osteoarthritic knee home to clean and jerk 100k, but I am suggesting that we need to consider these principles and be a little bit more imaginative and therefore effective with our home exercise programs. That if the conditions from a patient point of view and their pathology point of view allow it, we should be thinking about the type of exercise we give them. So for example, it's, you know, how effective is a straight leg raise in somebody with minimal pain in the knee, but in somebody that you've identified has a really weak quads. So your CSA, cross-sectional area, that's the word I wanted earlier, is essentially another word for hypertrophy, or sort of an increase in size. So this almost does sound like a statement of the obvious, but if you've got an increase in hypertrophy or your cross-sectional area, this impacts positively a muscle's ability to produce force and power. Greater muscle fibre cross-sectional area, particularly with those type 2 fibres, alters the force velocity characteristics of the whole muscle. So if you just think back to that video you watched, it talks about the cross-bridge interactions between the actin and the myosin. If we've got an increased cross-sectional area and we've increased from a type 2 fibre point of view, we've got increased number of cross-bridge interactions, which therefore increases our capability of producing more strength and power. Sort of increasing the cross-sectional area leads to changes in your muscle architecture, your fibre type and your motor unit recruitment, and it enhances our ability to increase the maximal strength we can produce. Musculotendinous stiffness. So again, we're sort of thinking about the factors that affect our ability to improve our muscle strength. So tissue stiffness is the relationship between the given force and the amount of stretch the tissue undergoes. And this is essentially the concept of tissues expressing a spring-like behaviour. So that's essentially their recoil. And so again, this is something to really think about if you are trying to, for example, improve somebody, you've identified that their calf is weak and you're trying to improve that. It's sort of being aware, have they previously had a tendinopathy in their Achilles, sort of structurally, how does that Achilles look now? And for those of you that have heard me talk about sort of fascia particularly before, it's considering the kind of connective tissue as a whole, your endomysium, your perimysium and your epimysium, and how all of the tissues surrounding a muscle can influence your capacity to improve strength and also your RFD. Firing frequency, just talked a little bit about this. Again, this is something we'll expand on in sort of future presentations. Essentially, your firing frequency is, as it says on the 10, it's the frequency at which the motor neuron will discharge action potentials to your motor units. And it can modify your force production properties. So if you've got increased firing frequency of your motor unit, you'll get greater force magnitudes and then greater RFD. And there is some research out there that shows that sort of ballistic training, getting patients to do movements more rapidly, obviously in the context of their pathology and their condition, may enhance their motor unit firing, which therefore should facilitate improvements in strength gains. Again, very similar, and it makes sense, your motor unit synchronization, possibly more related to your RFD, so your rate of force development or the speed at which that muscle can get to its maximum contraction potential. But again, resistance training, particularly heavy resistance training, is shown to increase your motor unit synchronization. Increased motor unit synchronization leads to improved neuromuscular control, which therefore feeds forward to increased force production, which takes me nicely on to neuromuscular control. So, very brief summary. Skeletal muscle works under the control of the nervous system, as everything works under the control of the nervous system. We get afferent feedback from all those receptors in our muscle spindles, our tendon organs, our joint, skin, etc. And really what neuromuscular control is, it's the subconscious integration of all that sensory information, which is processed by your central nervous system, and it results in controlled movement through coordinated muscle activity. Dynamic joint stability and postural control are the result of coordinated muscle activity, which is achieved through your neuromuscular control. So any injury to a patient that disrupts anything that's going to affect that whole feedback system, so your mechanoreceptors, ligament injuries, altered normal sensory input, or anything that interferes with that sensory information processing, will alter your neuromuscular control. And if you get an alteration in your neuromuscular control, you'll end up with altered dynamic joint stability, which will result in an altered movement pattern, altered recruitment, and which leads us ultimately to an increased risk in musculoskeletal injury. So that's sort of going around in a nice vicious circle, and obviously that's something we all know we're looking to sort of correct and address when we're seeing and treating our patients. So I hope that was a useful summary. It was a very much a whistle-stop tour through muscle physiology, but I felt it was really important for us to get back to basics, because if we are going to expand on some of these strength and conditioning concepts, it's obviously good to have that grounding, and just to go back and really think about how muscles actually work, what's the most effective and efficient way of improving strength for our patients. And essentially what we're hoping to do over the next few sessions is look to apply the principles of strength and conditioning to our particular patient populations, and create the most effective exercise programs that we are able to deliver remotely. References for this presentation, as I alluded to earlier, is a lady called Claire Mitchell. Get Back to Sport, if you search for her on Twitter, you can sign up to her blog. She does some quite interesting blogs. And she's done an online course on strength and conditioning for therapists. That's something that I am sort of working my way through at the moment. And the reason for that is that I sort of become really interested in it, and sort of how effective are we with our sort of management strategies, and how areas that I need to improve on personally as well. So if you are interested in that, don't necessarily sign up for it straight away from a course point of view, but just ping me an email, and I can sort of show you the content that you can sort of see whether you'd be interested in that. And then there's just a couple of articles that I've referenced that I've used mainly. There's a few other bits that I've dipped into as well, but it's the Grieg and Jones article on muscle physiology and contraction, and the Schuemel, I don't know how you pronounce it, on the importance of muscular strength training conditions, which was taken from one of the strength and conditioning journals. So I hope that was useful. Apologies again, that's not live. If you have any questions, anything you want to ask me, absolutely fine, do get in touch. I know I speak for sort of everyone. We say we're really missing seeing people in departments, so it would be lovely to hear from you. Just make sure, if you're new, if you look for me on the email, it's Stephanie Hewitt, and you just want to make sure you go with the NWBH email address, because there's two email addresses for me, which is another story. Okay, I hope that was good. I hope you enjoyed. Any questions to me, and look after yourself, stay safe. Thanks.